If this treatment doesn't work, or the cancer starts to grow, then we've got a couple of options.
I've got to spend $5,000 buying 1.8 months. And I thought, that's an experiment, really.
Modern medicine can buy time for cancer patients, but at what price?
There's absolutely no question it's costly, and it's a discussion for the community.
The life and death equations of cancer, human and economic. Welcome to Four Corners. One of the things we most dread in life is the big C. Cancer touches hundreds of thousands of lives in Australia each year. We're constantly hearing that cures are just around the corner, but for the 43,000 who died of cancer last year, the hope did not match the reality. So for all the talk of cures, the greatest progress in anti-cancer research in recent times has been the development of drugs that might slow or halt the advance of the disease and buy people a longer life. Apart from the lottery aspect, the downside lies in the cost. A course of treatment for one patient suffering from melanoma will cost more than $100,000 and on average give that patient a few more months to live. Put yourself in the victim's shoes. Of course you'd want to buy the time, so would your family. But the other side of the coin is the massive blowout in health costs the government and taxpayers face together, looking ahead. There are already 91 cancer-treating drugs available on the Pharmaceutical Benefit Scheme that cost $1.2 billion. Tonight, we go inside the hospitals and consulting rooms with a number of brave Australians who talk with courage and candour about their suffering and the crucial decisions they must make.
The Four Corners clip has introduced our topic extraordinarily well. Thank you, Kerry. Our topic explores the highly contentious issue around the funding of high-cost cancer medicines in Australia. The Pharmaceutical Benefit Scheme, known as the PBS, was established in 1948. The government, through the PBS, subsidises the cost of medicines which are listed on the PBS for all Australians who hold a Medicare card. The total cost of the PBS is uncapped. It is driven by patient utilisation of the medicines available. As new medicines are added and the utilisation of medicines already on the scheme grows, the cost of the scheme increases. PBS expenditure for the year ending 30th of June 2014 was just under $9.2 billion. There is an independent body in Australia called the Pharmaceutical Benefits Advisory Committee, whose members are appointed by the government and made up of doctors, pharmacists, health economists, and consumer representatives. Its role is to recommend new medicines for listing on the PBS. No new medication can be listed on the PBS in Australia unless the PBAC makes a positive recommendation. New medication must meet 5 criteria, and these include quality, safety, efficacy, clinical and cost-effectiveness, and financial feasibility acceptability. For medicines, Australia's Pharmaceutical Benefits Advisory Committee advises which drugs are cost-effective and should therefore be subsidised by government. If a decision is made not to fund a high-cost cancer drug for the Pharmaceutical Benefit Scheme, for instance, the PBAC is effectively saying the resources that would be used to fund the drug could be better used. That is, provide more health improvements for something else. These type of decisions do, of course, mean that some people lose out, but others gain. There are a number of key issues that relate to the high cost of funding cancer medicines in Australia, and these include the significant opportunity costs associated with subsidising these medicines, that the funding of alternative therapies or other public health initiatives could have wider benefits to the broader population. Spending on expensive cancer drugs leads to reductions in other cancer services and treatments, and these can include the early diagnosis of other cancers, high-quality surgery, and radiotherapy. That the fast tracking of getting high-cost cancer medicines on the market, Herceptin, for example, is resource intensive. There are a number of questions that also need to be asked, such as, how are we going to afford to deliver high-quality and equitable care, and in setting priorities about who is to receive treatment? And also, who decides who receives this treatment and who does not? We will now explore how the 4 bioethical principles relate to this topic. Autonomy in healthcare includes respect for informed consent. It values the relationship between the sharing of decision-making between the physician and the patient. The physician provides the information regarding treatments, and the patient provides their values. Informed consent includes the patient's right to say no to treatment, as well as their right to participate in medical decision-making. The principle of distributive justice is the fairness in the distribution of rights and benefits. Microallocation of healthcare is concerned with who is to receive a given treatment, and there are not the resources to treat everyone. It is not possible to give every patient the most expensive and newest drug, and therefore it is necessary to ration the resources to ensure that other patients do not miss out on medical treatment. Alistair Campbell outlines 6 principles that can be used to decide how to allocate resources fairly, and these are: to each an equal share, to each according to individual's choice, to each according to potential for future life years, to each according to what they deserve, to each according to their social usefulness, and to each according to their needs. We now explore the principles of beneficence and non-maleficence. There is a lack of thresholds for clinical benefits, and this is very subjective. How do you decide how much additional benefit warrants significant additional costs? Example, the opinion of medical oncologists, patients, families, and carers versus the government. Cancer diagnoses result in greater willingness to pay. Example, price elasticity, with patients and physicians so more likely to pay more for less benefit. There may be uncertainty of predicted benefits. For example, many newer agents have only been trialled for short periods. They may be fast-tracked if data is promising and a projection is made for significant health gains in the future. Once in the market, however, the drug may not display the same degree of benefits and could show increased harm if new adverse drug reactions are identified. Drugs can be improved on the basis of surrogate outcomes, and we cannot just consider the cost of the drug. The drug may have a clinical outcome which is no worse than a competitor, but may offer the advantages of a better safety profile. This may result in a more favourable cost-effectiveness and may warrant a price premium over the competitor due to better quality of life outcomes, or significant cost offsets due to better safety. An increasing number of newer cancer medication agents offer, statistically, significant incremental clinical advantages at considerable cost. For example, many of the new oncology agents offer a prolongation of life of a few months, but at generally unacceptable cost effectiveness. A recent editorial in the New England Journal of Medicine indicated that in the past decade, the survival gain in cancer of the colon has doubled, but the cost of the therapy has increased 320-fold. Our recommendations to the government: 1. There should be an explicit public debate about the principles and issues regarding subsidizing high-cost cancer therapies. 2. The public should understand that healthcare resources are limited and choices need to be made. 3. Consider redirecting money used to subsidized high-cost, non-curative medications to cancer prevention strategies as well as research. 4. Governments work with pharmaceutical companies and subsidize the cost of drug development to reduce their cost and reduce risks associated with drug development. Professor Jonathan Sibon, a leading investigator in the Australian clinical trials for the melanoma drug Yervoy, says, "There is absolutely no question it's costly. If you talk to a patient or to their family, there's no question in their mind that it's worthwhile." So to conclude our presentation, we have 2 questions for the class. 1. Do you think the government should fund the cost of all cancer medicines, regardless of the cost? And 2. How much of the public health budget should be justifiably allocated to high-cost cancer medicines?